Every day, anesthesiologists balance a delicate physiological equation, reconciling a patient's existing systemic disease burden with the introduction of targeted, highly potent pharmacological interventions. To quantify that pre-existing medical burden, clinicians rely on the ASA Physical Status Classification System. This specific classification framework has been continuously utilized for over 60 years to standardize the assessment of preoperative comorbidities. The ASA classification system operates strictly as a communication tool, rather than an independent predictor of perioperative risk. To hold any real predictive value, this preoperative baseline must be synthesized with the specific procedural variables and pharmacological agents introduced during surgery. This baseline assessment eventually meets the gold standard of intraoperative care, the administration of highly potent intravenous opioids like fentanyl, sufentanil, or remifentanil. While these agents provide profound surgical analgesia through precise cellular mechanisms, that same precision creates incredibly narrow therapeutic windows for patients presenting with high systemic risk. Perioperative risk emerges as the direct product of systemic comorbidities colliding with targeted opioid cellular pharmacology. This table outlines the ASA framework. To understand where surgical risk accelerates, we need to analyze the precise clinical threshold separating Class 2 and Class 3. An ASA 2 assignment indicates a patient presenting with mild systemic disease, without substantive functional limitations. An escalation to ASA 3 requires a severe systemic disease, accompanied by substantive functional limitations. In terms of respiratory health, an ASA 2 patient might present with mild to moderate obstructive sleep apnea, or a BMI between 30 and 40. The progression to ASA 3 occurs when those conditions advance to severe OSA, or morbid obesity. Determining this specific shift from mild to severe requires evaluating the steady erosion of the patient's underlying respiratory and hemodynamic reserves. Correctly stratifying a patient into ASA 3 identifies a structurally compromised respiratory architecture that is critically vulnerable to pharmacological depressants. To see how these depressants act on that vulnerability, we must scale down from the macro assessment into the microenvironment of the synaptic cleft. Intraoperative opioids exert their primary mechanism of action by binding directly to mu, delta, and kappa G protein-coupled receptors. The process starts when the receptor and opioid ligand interact, activating the associated G protein and causing it to physically split into distinct subunits. In the first parallel action, the separated G-alpha subunit directly alters potassium channel conductance, triggering an efflux of potassium ions from the cell. This rapid outward shift of positive ions drives the cell membrane into a state of profound hyperpolarization. Simultaneously, the G-beta-gamma subunit acts to reduce calcium channel conductance, blocking the influx of calcium. The combination of hyperpolarization and calcium blockade drastically reduces overall neuronal excitability. This cellular state produces the required analgesic outcome, disrupting nociceptive signal transmission by modulating the release of substance P. The anatomical result is that nociceptive signals are effectively blocked from traveling from the peripheral nervous system to the cortex. The cellular mechanism responsible for essential surgical analgesia is inherently disruptive to baseline neuronal firing across all affected tissue. Scaling back up to the central nervous system reveals where these opioid receptors are tightly clustered. The intended analgesic effects originate from heavy receptor activation in the periaqueductal gray and the rostral ventral medulla. But these receptors are also dense in the brainstem, specifically at the pre-Boettinger complex, the primary site where critical adverse events originate. When opioids bind at this specific anatomical site, the activation inhibits adenylate cyclase and G protein-coupled inwardly rectifying potassium channels. The clinical manifestation of this localized neural inhibition is severe respiratory depression and the potential for total apnea. This graphic maps the structurally compromised physiology of an ASA 3 patient directly against this pre-Boettinger inhibition. Introducing a mu receptor-mediated respiratory depressant to a patient with an already structurally compromised airway exponentially increases the risk of postoperative failure. This acute respiratory compromise can quickly trigger secondary crises, such as hypercapnia, which drives a dangerous increase in intracranial pressure. Predicting clinical failure requires mapping the specific functional limitation of an ASA Class 3 patient against the off-target receptor bindings of opioid anesthesia. The modern clinical response to this systemic pharmacological intersection is the deployment of enhanced recovery after surgery protocols and multimodal analgesia. The strategic goal of these pathways is to achieve early recovery by maintaining preoperative organ function while strictly minimizing opioid reliance. This graph illustrates the recent clinical data driving the shift, specifically the findings from the SOFA, or Standard versus Opioid-Free Anesthesia trial. The trial demonstrated that opioid-free protocols yield statistically significant improvements in patient recovery quality at the critical 24, 48, and 72-hour marks. Instead of relying entirely on opioids, this multimodal approach manages pain by targeting alternative pathways, utilizing alpha-2 agonists, NMDA antagonists, and gabapentinoids. The molecular advantage is precise. It achieves the necessary descending inhibitory signaling for surgery without activating the mu receptors housed within the respiratory centers. Multimodal regimens physically bypass the physiological choke points of high ASA status patients, effectively separating surgical analgesia from respiratory depression. Managing this level of precision expands well beyond the localized pharmacology of the operating room and requires the broader postoperative interprofessional healthcare team. Balancing complex multimodal regimens alongside ASA stratified risks mandates strict coordination across physicians, clinical pharmacists, and perioperative nurses. Failures in closed-loop communication regarding intraoperative dosing history can quickly result in duplicate prescriptions, prolonged sedation, or severe toxicity events. Complete team-wide alignment ensures correct dose conversions, identifies dangerous drug interactions during shortages, and maintains strict adherence to postoperative pain protocols. When the ASA classification serves as an active roadmap for receptor-level intervention, it ensures maximum patient safety within a multimodal anesthesia framework.